How has DLBCL treatment evolved from chemo to targeted therapy? Imagine a journey from one treatment approach to another, driven by better understanding and innovation. That's exactly how treatment for diffuse large B-cell lymphoma has changed over time. In the early days, doctors relied mainly on combination chemotherapy, especially a regimen called CHOP, which includes drugs like cyclophosphamide, doxorubicin, vincristine, and prednisone. This approach was effective for many, but it wasn't perfect. Some patients did not respond or relapsed after treatment. The big breakthrough came with the introduction of rituximab, a monoclonal antibody that specifically targets the CD20 protein on B cells. When rituximab was added to the CHOP regimen, creating R-CHOP, outcomes improved significantly. This combination became the standard frontline treatment because it increased survival rates without adding much extra toxicity. Typically, patients receive R-CHOP in cycles every 21 days, usually for about 6 cycles, depending on their disease stage and overall health. Adding rituximab was a game-changer, especially for early-stage disease, where it improved both event-free and overall survival. Sometimes, radiation therapy is used in conjunction with chemoimmunotherapy, but it is not enough alone to cure the disease. Despite these advances, about 40% of patients still face relapse or treatment resistance, which posed a real challenge. In the past decade, researchers have turned to targeted therapies and immunotherapies to improve outcomes further. These newer approaches aim to attack the lymphoma more precisely, sparing healthy tissue and reducing side effects. For example, drugs like lenalidomide, ibrutinib, tafasitamab, and acalabrutinib have been tested in combination with rituximab and chemotherapy. Some of these combinations have shown high response rates, and in certain cases, they allow doctors to reduce or even skip some chemotherapy cycles for patients who respond deeply. Another exciting development is polatuzumab vedotin, an antibody-drug conjugate that targets CD79B on lymphoma cells. When combined with rituximab and chemotherapy, this drug has shown promising results and is being used as an alternative frontline option. Treatment is also becoming more personalized, based on the specific subtype of lymphoma and its biological features. For example, primary mediastinal or testicular lymphomas may receive tailored regimens that include targeted therapies, radiation, or CNS prophylaxis to improve outcomes. Immunotherapies and new agents targeting immune checkpoints or specific pathways are also being investigated. These are especially useful for patients whose disease has relapsed or become resistant to initial treatments. Overall, the evolution from chemotherapy alone to chemoimmunotherapy and now to targeted and immune-based therapies reflects a deeper understanding of lymphoma biology. The goal is to improve cure rates, reduce side effects, and offer more personalized options for each patient. While R-CHOP remains the mainstay of initial treatment, these newer therapies are increasingly being integrated into practice, offering hope for better outcomes in the future. Always remember, treatment decisions should be made in consultation with healthcare professionals who can tailor approaches to individual needs and circumstances.